Hello everyone, this is Ahmed Al-Mazrou, one of the general surgery residents at NewYork-Presbyterian Hospital, Weill Cornell. I would like to thank SAGES for the opportunity to present our work today. This study is funded by the Intuitive Surgical. The robotic technology has several unique features, including the three-dimensional visual information, in addition to the wrist movement and the fixing arm of the robotic instrumentation. These features allow surgeons to have minimal intraoperative fatigue and strain. Several studies looked at the outcomes of robotic colorectal surgery when compared to conventional approaches. Most of the studies found that the short-term clinical outcomes of robotic colorectal surgery to be better than that of open colorectal surgery. However, the outcomes of robotic colorectal surgery when compared to laparoscopy were the same clinically. Studies that looked at the in-hospital costs found that robotic colorectal surgery to be associated with higher costs when compared to other approaches. Few studies have evaluated the post-discharge outcomes between robotic and laparoscopic as well as open colorectal operations. Most of the studies that looked at the difference between robotic and laparoscopic colorectal surgery found comparable 30-day post-operative readmission. Few studies found potential reduction in 30-day post-discharge readmission for robotic colorectal surgery when compared to laparoscopy. However, it is still unclear whether robotic technology has impacted the long-term outcomes of colorectal surgery when compared to conventional approaches. The objective of this study is to evaluate the long-term effects of robotic technology on resource utilization after colorectal surgery. Using primary prospective data between 2007 and 2017, we identified adult patients who underwent elective partial colectomy or proctectomy. Patients who underwent urgent, emergent procedures were excluded. Patients with history of transplant were similarly removed from the analysis. Eventually, more than 200,000 patients were evaluated. Of these cases, 46.7% were open operations, while 46.4% and 6.8% were laparoscopic and robotic operations. For the colectomy cohort, the robotic colectomy group had younger patients who were male individuals with lower APR-DRG severity levels. The robotic colectomy group had more comorbid patients when compared to laparoscopy and open approach. Robotic colectomy was most likely performed at hospitals located in the northwest part of the country, at urban and teaching institutions that were large. In the proctectomy cohort, similarly, robotic group had younger patients with lower APR-DRG severity score. However, comorbidities were more likely to be higher in the open proctectomy group. Hospitals that performed robotic proctectomy were more likely to be located in the South Midwest, and these hospitals were more likely to be large institutions. Looking at the outcomes for both cohorts, robotic technology was associated with lower rates for discharge to other facility, meaning extended care after discharge, within 60 and 90 days after discharge from the index procedure. When readmitted, the robotic cohort for colectomy and proctectomy had lower rates of multiple readmissions when compared to conventional approaches for the 60 and 90 days after the index operations. When readmitted, robotic group tended to have lower hospital stay when compared to open technique. Looking at costs, robotic group continued to have higher index hospitalization costs. However, the room and board costs within 90 days for robotic group was significantly lower than laparoscopy, an open approach for both partial colectomy and partial proctectomy. This graph illustrates the utilization of other facilities after discharge. As you can see here, that the robotic group continued to have lower rates of other facility placement after index procedure. There are several limitations of this study, including the retrospective nature of the analysis. Premier is an administrative database which lacks clinical information, and we were not able to identify any readmissions or other facility placements for patients who were readmitted at hospitals that are not captured by Premier data. One of the future plans is to detail the cost analysis by combining the in-hospital with the 90-day post-discharge costs to see if any post-discharge cost saving has impacted the overall costs of robotic technology. This study suggests a potential recovery advantage of robotic technology after discharge following colorectal operation. It is possible that the adoption of robotic technology may minimize post-discharge resource utilization after colorectal surgery. Thank you very much.